Hello, everybody, and welcome to today's webinar, Rehab Agency Survey Accreditation Update. We are very excited for our presentation today. There's lots of information that is going to be covered. My name is Sabrina McCarley, and I will be the moderator for today. A couple of housekeeping items that I'd like to cover with everybody. First, all attendees are going to be on mute. We are recording today's webinar. A couple of tips for today's handouts. Christy is posting a couple of items in the chat box for all of you. There were handouts that were also sent out about an hour before today's presentation. We do ask that if you have any questions for our speakers that you type those into the Q&A box. If you have any technical issues during today's webinar, we ask that you use the chat button and Christy will get the assistance for you. For the recording, we will be emailing this out to all registered attendees in about 48 hours after the recording today. It will also be available for all NARA members on our portal in approximately 24 hours. So with that, Nancy and Laura, I'm going to turn it over to you.
Great, thank you, Sabrina. We have a great webinar planned for you today. It's filled with information that a rehab agency won't want to miss out on. We'll be covering the CMS survey and certification memos, the new Quad A infection control worksheet, and changes that are required in your policies, procedures, and your processes. We'll share resources from Quad A, from CMS, and the CDC, and have tips from our panel toward the end of the webinar. We have a tight timeline, as you can imagine, so we want to just get started right away. Nancy, are you ready to go?
Laura, I am ready to go, and I've just got to get this my buttons in the right direction here.
Well, while you're doing that, let me say one more thing. I'm showing a fine print slide right here. This is just a simple reminder that this presentation and our panel comments do not contribute or constitute legal advice or consulting advice. So please remember to always go to your source documents for information. One more thing. Sorry, Nancy, I'm not ready to go to you yet. I'm Laura Riddell. I didn't introduce myself. I'm the Chief Compliance Officer for Mountain Land Rehabilitation. Joining us today, we have expert panelists that include Mark McDavid from Seagrove Rehab Partners, Julie Beckley with Empower Me Wellness, and Dick Hillier, who is a board member for Quad A, and of course, Nancy Beckley of Nancy Beckley and Associates. You'll have an opportunity to hear from each of our panelists a little bit later in our webinar, but for now, let's turn this over to Nancy to start the presentation.
All righty, thanks, Laura. And I'm going to turn myself off of the video here, and we'll see you all back when we go back for our panel discussion. So for rehab agencies, there are 12 conditions of participation, interpretive guidelines to assist surveyors, and Quad A accreditation standards, all informing a rehab agency as to how their required policies and procedures need to be set up. There are a few things that may be of interest here this morning. While our focus is on rehab agencies, the items related to infection control and emergency preparedness are also applicable under the CORF conditions of participation. And a couple of additional fun facts. The CMS database as of December 31st contains 2,022 rehab agencies with a net loss of 32 in the last year. There have been 7,301 rehab agencies certified since the start of the program in the 70s. There are 159 CORFs, a drop of about 20 in the past 2 years, and there have been 1,603 CORFs certified since the rollout of the CORF program in 1983. Let's take a look at the changing landscape of rehab agencies. A traditional rehab agency has been what I call the traditional outpatient, likely orthopedic therapy practice, located in the community with drive-up access, spacious interiors, open gym space, private treatment rooms, and often in-house aquatic therapy facilities right in the clinic. And thanks to Mountain Land for sharing these beautiful pictures. Let's take a look here at a venue that's a newer venue for rehab agencies. I call it the changing landscape with assisted living and retirement communities. So this is taking on a different style, a different program approach, and a different appearance although the conditions and standards still apply. The Elizabeth residence is right up the street from my house, and I clipped the Athens Physical Therapy room from a Facebook webpage. As we continue to move through this important regulatory and compliance update, we'll reference back to the risk assessment variances that our attendees should take into consideration based on the size and scope of your rehab agencies, including your approved extension locations. The emergence at the fall conference a few years ago when Laura and I chaired a panel that included Dick Hillier, and he famously said, and is frequently quoted by us, that using a big white bullhorn is not an acceptable method of alerting to a fire or disaster in lieu of a local alarm system. So Dick, my friend, this is for you. Thought you'd get a kick out of that. At the end of December, CMS updated their infection control focus survey tool for state survey agencies. Prior to that, in March, CMS issued an update that included rehab agencies and CORFs, instructing them in taking appropriate action to address potential and confirmed COVID-19 cases. That guidance in March discussed recommendations to mitigate transmission, including screening, restricting visitors, cleaning and disinfection, and possible closures. So theoretically, your policy should have been updated at that time. The second memo, which is the heart of what we're talking about today, on 12/30, included updated CMS COVID-19 focused infection control survey tool for acute and continuing care to help and ensure an effective assessment of the provider's implementation of appropriate infection prevention standards. That's a mouthful from CMS. The CMS revised survey tool took into account updated guidance from the Center for Disease Control. During the last week of January, Quad A emailed their accredited rehab agencies their updated survey protocol, including a copy of the surveyor worksheet and worksheet instructions, which are in your handout packet. Effective February 1st, the worksheet is now utilized during on-site surveys. However, Quad A strongly suggests that all facilities review their policies and procedures in light of the guidance provided. Quad A is contemplating making this a part of the self-assessment process for years 2 and years 3. So you see a little quote there, which is a quote coming back to the NARA group in response to a question to Quad A of what's this all about. Here are the 12 conditions of participation for a rehab agency. They should be recognizable to all. But the regulatory updates of importance for today are administrative management, physical environment, infection control, emergency preparedness, and program evaluation. So let's go through those standards and refresh our memory on that. Under the administrative management, I want to point out that personnel and patient care policies are now going to require updates in light of CMS guidance and the changed survey protocol. Personnel policies must describe selecting personnel, assessing their competency, their continuing education requirements, hiring and firing, and staff evaluations. That's already in the standards. Patient care policies must be developed by your group of professional personnel and must be reviewed and documented on an annual basis. We'll get to some of these changes in a few minutes. The applicable standard under physical environment is only for those that are performing aerosol generating procedures. So if you're not doing that, this is a non-applicable standard. Infection control is a wild card condition. You know, some surveyors go wild on this. I think that's why we call it a wild card condition. These items in your clinic grab a surveyor's attention when they're in a rehab agency or a physical therapy clinic. Are the cracks in the plinth covers, which create infection hazards, cleanliness of your privacy curtains, is TheraBand sanitized? And in fact, some surveyors have suggested that patients need to be issued their own TheraBand and is stored much like practices store patient electrodes. In the last NARA rehab agency webinar that Laura and I completed, Laura recommended using a cleaning checklist that was essential in order to document your infection control practices and to be sure to keep your copies available. That's even more so now that you maintain those checklists. The emergency preparedness condition replaced the disaster preparedness condition in November of 2017. I can't overemphasize the importance of compliance with all the substantial requirements of emergency preparedness condition for your next survey. So it's no longer a new area for surveyors. It may be a new area for an existing rehab agency that have not had a survey in the past 4 to 5 years. In 2020, CMS added updates addressing COVID response, and in a bit of irony, reduced some requirements in 2019 as part of the President's CMS Burden Reduction Initiative. Be prepared, don't wait. You won't be able to make up a plan of correction on this condition in the time allowed for you to get your plan of action together. As a reminder, there are 20 standards and really 10 different policies that you have to put together just in emergency preparedness. The 12th condition of participation is program evaluation, and that received an update related to compliance monitoring. This is the Quad A updated surveyor worksheet that was effective for surveys beginning February 1st, 2021. And Quad A deployed this across their entire platform of CMS accredited programs, but they crosswalk the standards by program. So the standards here are crosswalked to rehab agencies. So now that we know the conditions, let's move on and take a look at this survey tool. This is the surveyor instruction worksheet, and these instructions also included are with your handouts. They give guidance to the surveyors to review policies, to interview staff, and observe. That's a traditional thing that's done on a survey. And the guidance, now keep your eye on the blue box here, is for infection control policies, your emergency preparedness plan, and your educational logs and your audit tools. Keep your eye on the blue box. We're moving along here. The surveyor instructions, which were included, give guidance to surveyors, once again, infection, emergency preparedness, and education laws, but tools in the context of policies and procedures, compliance surveillance, your documentation of your staff training, your scheduled and your patient interactions with your scheduling and patient interactions, supplies and equipment, environment and disinfection, and your emergency preparedness plan. So as we keep rolling, you'll see that I'm trying to slice it and dice it a couple of different ways here. This is Quad A's first survey content area of policies and procedures. These are the suggestions that Laura and I have for policies and procedures in the left-hand column. Of note, and Dick reminded this to me last week when we spoke on the phone, they don't all have to be individual policies. If collectively done in a huge policy or a dictated policy, it should be identified as to the policy and the specific procedure, as well as the required tracking and documentation methods. So take a look here at some of the policies and procedures we've recommended, and I've indexed the standard straight off of the Quad A sheet, where they're going to crosswalk it to the accreditation standards. This is Quad A's survey content areas that include compliance surveillance, documented staff training, scheduling and patient interaction, and the emergency preparedness plan. Once again, these are mine and Laura's recommendations for updated policies, but this is how those areas are crosswalked to the accreditation standards. And Quad A survey content areas on this slide include supplies and equipment and environment and disinfection. These are once again suggested policies and procedures. I'd also like to share that these are the same areas that state surveyors were also focused on. Laura and I spent quite a bit of time going through these because there are many rehab agencies, including Mountain Land Rehab, that are not accredited by Quad A. So the question is, are these applicable for us? And these are from CMS. Quad A is just simply transporting to their constituency group how they're going to assess them. A few months ago, I heard from a rehab agency that they had to have all of their cloth-covered chairs in the waiting room and in the clinic replaced. The state surveyor basically said, you won't pass and we're not coming back till you can tell us you've changed out your chairs. So it does apply to the state agencies. Laura and I have done a fair amount of collaborative work on compliance program effectiveness reviews. And in fact, what's neat is Laura sat on the OIG HCCA Select Committee that developed the Compliance Program Effectiveness Tool that's published by the OIG. In compliance, risk assessment is always the first step. So that's where we're starting, as we're going to walk you through taking a look and beginning to assess risks with respect to all of these updates so that you can prepare your policies and procedures. Remember this picture? Well, now it takes on a different point of view. Let's start in the parking lot. And of course, I can't help but notice those beautiful mountains in the background. And you approach the front door. And remember, the surveyor's assessing risks, so they approach the front door. In consideration should be outdoor signage that addresses issues prior to opening the door or anyone entering the clinic. For example, signage that may indicate by appointment only, that masks are required, that you will be screened upon entering, and any other local signage that's required. I know that I live in Milwaukee, but there's 5 little burgs around me, and each of the little burgs seem to have a different little spin on the signs that need to be on a door for businesses that are open. Remember the ALF up the street from me? Well, now consider how this is applicable both at the outside door to the assisted living facility, as well as the door to the rehab agency clinic that would be inside. So what's applicable? How are the surveyors going to look at it? Is the ALF going to let you have outside people in it? And will state regulations for assisted living facilities allow you to have outside people? Medicare beneficiaries, remember, can go to any rehab agency. Your assessment continues now as you enter the rehab agency and square up with the reception area and the front desk. So have you adequately addressed inside your COVID-19 signage, that you're going to be visitor testing, patient testing, your hand hygiene protocol, the seating distance in your lobby, the chair coverings, that you're removing all magazines, that you're covering the bubbler. Well, in Wisconsin, we call it a bubbler. It's a drinking fountain. And how to pull Kleenex out of a box. Notice I've put a Purell dispenser there that's a hands-free dispenser, because everybody pumping on the same Purell dispenser that you have to hand pump really isn't good infection control procedures. So let's take that now to the ALF up the street and efficient rehab agency clinic. The same is applicable. So you begin to see the risk assessment here takes on a very, very different context. I think this is a really nice looking small therapy clinic, very efficient. You see the fax machine in the back, the ultrasound e-stim machine, the recumbent bike, the weight rack, the high-low table, and a chair. But take a look at, how many people are you going to be putting in there? And what do you have to do to adjust your policy? Grab your clipboard and walk along with me, as our next risk assessment checklist is going to be entering into the treatment area or treatment areas of your clinic. So you see the masking tape on the floor, which is very traditional in an outpatient clinic, where the therapist masks off stuff for different levels of exercises and whatnot. So you're going to want to visually, or maybe actually, get some of that orange duct tape and mark off your 6-foot areas or your therapy exercise parameters related to your capacity, your safe distancing, any cloth covers, chairs, or items that may be in your clinic. Take a look at your linen processes, your clean and soiled linen, your curtains, which we mentioned a little bit earlier, various different types of equipment that you have, TheraBand, and sharps and hazardous waste. So what notices do you need to have in your clinic, and where are you going to put there your Purell dispenser? And I've got one that you stick up on the wall. Now we're going to go back to our smaller assisted living facility and take a look through a different lens. The scenario spins quite a bit, doesn't it? But the same requirements are there. So handling capacity, safe distancing, the cloth covers, linens, curtains, no curtains in here, but equipment, TheraBands, and any sharps or hazardous waste. And I say that because so many people are doing dry needling, not wound debridement. And the last assessment for risk is a page-by-page assessment of your online electronic policies and procedures, or your digital policies and procedures, as well as those paper and pencil things that you might have handy in your clinic. For example, collecting the results of your disaster drills, committee meetings, and the like. So all are available to surveyors. If the surveyor is going to sit down at your computer, what are your infection control procedures for the computer? I've put a little link into there to a great little tidbit from Apple about disinfecting products. And don't forget to update your personnel files, as selected files will be reviewed during the survey. This next section gets back to the heart of the matter. How does this all go back to updating our policies, procedures, and processes? We'll start with the administrative management condition. And I look at that slide, I grabbed it and I said, that's a lot of management right there from whatever type of a plant that is. I'm impressed. Highlights for patient care policies and procedures include addressing patient scheduling, cancellations, and no-shows. If you're troubling with that and you don't know when people are going to come, that's going to create a problem on your schedule. Deferring non-emergent care, which is a requirement from CMS, your patient flow through, the volume in the facility. What's your visitor policy? And I put in there the context of we have translators we're required to provide, and we have patients that might come with caregivers. And then the switch to telehealth, which is encouraged in these standards. Under highlights for personnel policies and procedures, be sure to get guidance from your HR officer or your source where you get those policies, and comply with employment law applicable to your state, as well as complying with state, local Department of Health mandated reporting, updating your job descriptions, including the training that you've done for people, returning to work after COVID-19 exposure, and the mandatory reporting to your Department of Health, any other health entities, and mandatory reporting to Quad A. This is a nifty little tidbit here on deferral of patient care and the potential for harm. And it's lined out as deferral of patient care was considered high if it's likely to result in patient harm, medium if it may result in patient harm, and low if it's unlikely to result in patient harm, that you defer inpatient in-clinic treatment. I've got an article posted here that was recently noted at APTA that speaks to a research article completed and published last month that talks about the lack of diversion to telehealth during the beginning of the COVID-19 crisis. The only specialty lower than PT in the adoption of telehealth was optometry. So this is the tool right here for the provision of non-COVID care, and it shows the algorithm showing that PT and OT are generally identified as less likely to impose harm if therapy is delayed. As you're establishing policy at your practice, be sure to understand your process for accepting patients, deferring patients, moving them to telehealth, and do your numbers show that you're following your policy? Remember, numbers and things like this are part of program evaluation in rehab agencies. So I think this ties in nicely. I've developed an employee screening tool using CDC references, just as an example to show today. Be sure to check with your HR department to properly implement and document employee screening. And remember, your surveyor will be asking for your documentation of employee screening. I wanted to highlight on this slide how I've updated my own policy and procedure manual to show, as required in the CMS update, where changes and updates have been made. So the surveyor is going to ask, where have you made an update in your infection control policy? So that's the one that I picked here. And you can see where I've identified in red the specific date that I've updated. And then these are the corresponding dates that I made January 31st, but I made updates when all the CMS memos came out, the one from David Wright last March and various other updates. So keep track of this and highlight it some way when the surveyor says, can you please show us what changes that you've done? Let's move on to infection control. I won't read all the highlights here, but suffice it to say there's much work to be done. And then perhaps more importantly, from a survey perspective, documenting that policies and procedures have been implemented, such as minutes of your infection control meeting, using of checklists and various record keeping that I mentioned before that Laura said really central to infection control are a lot of checklists, a lot of documentation, and a lot of mitigation as a result of it. This is a handy tool that I found on the CDC's website to demonstrate personal protective equipment supply and inventory. While not terribly a huge concern right now in rehab agencies, at the beginning of the pandemic, it certainly was, and we all talked about it on the NARA Friday calls that we had. I can't remember the name of the calls right off the top of my head, but we talked about them on our Friday calls of people really desperately trying to get PPE. So take a look at this tool, identify that they've made it very nice, fill in the blank with the pictures of N95 masks, regular masks, and other PPE equipment. And then for a rehab agency, generally speaking, we would be supplying according to the conventional standards and really not so much in contingency. And a rehab agency actually should probably not be open and operating and if it's in a crisis. And that's really intended for bedded facilities that did have to operate during a crisis with limited access and had to use contingency plans. Those of you that know me know that emergency preparedness is my very favorite condition, and I dare say it for Laura also. We jointly developed a number of resources and tools when emergency preparedness replaced the disaster condition, and we rolled out a NARA webinar, which you could probably still find, that was covering emergency preparedness at that time. While updates in this area of emergency preparedness are a few, as noted earlier, if you're not started on this, there's a lot of work to do, including updating your all hazards risk assessment to address emerging infectious diseases, which was required 2 years ago, and updating to include a pandemic almost a year ago at this time. So I'll ask the question to everybody, have you activated your emergency preparedness plan during the pandemic? And if so, have you completed a hot wash or are you doing rolling hot washes? I think this will be a great topic during our Q&A and panel discussion. The last condition is program evaluation, where the accreditation standard for auditing compliance was crosswalked. Personally, I was pretty much thrilled to see this update directed at monitoring infection control compliance, and I had just the tool to address it. I uploaded my longtime monitoring and auditing tool, and I updated categories to address infection control surveillance and compliance education and training. While not required in the accreditation worksheet, as compliance professionals, Laura and I immediately went to the consideration of compliance response and prevention and compliance reporting and mitigation. So it all fits in nicely together from a compliance perspective. We've gone through a lot of material. Nothing really looks hard on face value, but we can assure you that this is not easy, particularly if you're not prepared and don't have a sense of where you're headed. And hopefully the organization that we've put together in this webinar and our conversation with our panelists will help you get in that direction. Take an inspirational look at the diagram in the context of the rehab agency required professional committee. I really couldn't say it better than what the diagram says. As a bonus round, I've prepared a record of attendance for submission to the Compliance Certification Board. And I'll tell you, there's no guarantee on the part of NARA or myself that the application for CEUs will be approved. I'm just lining it up so that you can submit it through the normal course of submission to the Compliance Certification Board. Shoot me an email by next Friday, and I'll personalize this attendance record for you to upload to the certification board. With NARA's permission, I've included this slide of references. Now I'd really like to get on to our panel discussion and Q&A. And Laura, are you ready to get going?
I'm ready. Thank you, Nancy. That was a great deal of information, and it was very helpful to hear all in a single context. And if panelists, if you guys will all join us on camera, that would be great. I know that everybody's looking forward to hearing from our panel, so I want to move right to our discussion. And Dick, I'm going to start with you with my first topic. I'm going to start with, when did CMS inform the industry of the new infection control standards? And when will surveyors expect a rehab agency to be in compliance with the new infection control guidelines? Dick, you're muted, so you'll need to unmute. Happens to all of us.
There.
There you go.
Laura.
Good.
I appreciate that. And it was great information. Appreciate it, Nancy. Similar questions came up when we had the switch to the emergency preparedness standards. It turns out that last spring, CMS started telling people what they wanted them to be paying attention to. And then the next information that I saw was around the 20th of June, I think, or it was June 2020 anyway. And then it was there was information that was promulgated in December, and then in January, NARA shared it with the various agencies. NARA, as Nancy said, is basically a conduit. We take what's in the standard in the state operations manual, and our leadership has pretty much distilled it down into objectives. Is the document there? May I see it, please? Is it documented that the trainings happen, things like that. So basically, it's been slowly coming out over the last year, and then in January, we shared it with everyone.
And when do you expect compliance?
According to CMS, compliance expectations was as of about 2.5 weeks ago on the 1st of February. So if someone had a scheduled survey that they knew was coming up in the 1st or 2nd week of February, they were accountable to have already completed this information.
Very good. No pressure, right?
No pressure.
No pressure.
And you know, so often we end up saying, I'm just the messenger.
We won't shoot you.
We pass it on. But the good thing is, you know, for the folks who are accredited, rather than surveyed by the state agency, they pretty much know about when their 3 years is up on accreditation and when they're going to have their next inspection. For folks who don't, they're there when they get there, and they expect. There are people who have not yet been surveyed on the emergency preparation standards, emergency preparedness standards. And when that first happened, states were finding people who just, we were finding people who were just amazed that that they were expected to do these things. We had people literally just about give us a deer in the headlights look, like, what? I'm supposed to, huh? All I do is get patients and treat them and get paid. What do you mean making me do all this administrative stuff? That's why they need consultants.
True that. So it's important to be ready when we can be ready, and be aware when we can be aware, and be ready when we're not aware as well.
All the time. When CMS sends out a notification that something is going on, somebody in the organization needs to read it, not just throw it away. And then they have to always ask, is there any implication to me? Do I need to be doing something? And if I can't do it myself, do I need to be calling somebody who does do this stuff and get them on the way? Rehab is no longer just a simplistic thing for people to engage in. In the late 90s, the feds decided that every healthcare provider was an essential part of the national infrastructure for healthcare and was necessary. And we saw that happen with fires in California. We saw it happen with Hurricane Katrina and several others. We've seen it happen with the pandemic. We will see it with other things. The feds expect that we are part of what's going on.
And that we're prepared. So good points, good
Be
reminders. Julia, my next topic is for you. Tell us a little bit about EmpowerMe Wellness and what you're doing differently to ensure compliance with the regulatory updates that we've discussed today.
Yeah, so EmpowerMe Wellness operates in assisted living, independent living, and memory care communities. So unlike your traditional brick and mortar outpatient clinics, we simply don't have the option to ask our COVID positive patients or symptomatic patients to stay home. Our therapists are working with primarily that high risk geriatric population with those compromised immune systems, the comorbidities, and truthfully, these residents need us more than ever right now. So the short answer is we're doing a lot of things differently. Throughout the past year, we've had to create and implement a number of policies and procedures, which Nancy touched upon earlier. So, we wrote our general COVID-19 policy and procedure, our daily employee signs and symptoms screening form, return to work policy, our telehealth policy and procedure, our policy on direct supervision via telecommunications, and then we created checklists based on the positivity rate within our host communities. So for example, if there's one or more positive cases within our community, we initiate our red level checklist. So that policy would include, guidelines for treating those COVID positive or quarantine patients, and treating in a patient's home versus in the clinic. So, I touched on, we created our daily employee screening form, including symptoms, exposure risks, temperature checks. Our patients are screened each morning by the community, so that communication with the community staff is imperative so that our therapists are prepared to know the extent of PPE needed. But of course, they are also screening patients at the initiation of those therapy services as well. We also immediately initiated routine weekly testing of our therapists. So, but if a county positivity rate is higher than 10%, we are testing our therapists twice a week. We've really had to adjust our staffing model and really our practice model too, to minimize traveling between our clinics and our communities. So for example, if that red level checklist is initiated because there are one or more positive cases in a building, our therapist is not able to travel between multiple clinics. That has really given us the opportunity to initiate telehealth services. So for example, our supervising therapists who are not able to travel between those communities, they're using those telehealth visits as a way to complete supervisory visits. We're using those PTAs, those CODAs as an extender with the patient in their room, helping them operate those devices and providing standby assist, contact guard assist as needed. And then, also utilizing those the allowance of the supervision via direct telecommunications. So, another way we've had to adjust our model is with treatments surrounding our policies on the use of the clinic space. So like I said, if there are any positive cases, our therapists are treating in the patient's rooms. They're not bringing people down to our clinic space in those assisted living communities. So our therapists really have had to be creative with those interventions within the patient's apartments with sometimes little to no equipment. And we have done a lot of research and purchased equipment that can help with those positive outcomes, but that can also be more mobile and easily sanitized, things like that. If there are no positive cases in our communities, we are bringing our patients to our clinic and then certainly implementing those things within the four walls of our clinics that Nancy touched on. So those distancing guidelines, the frequent sanitation, disinfecting equipment between patients, and then also, like Nancy touched on, is being creative. And as you saw, many of our clinics have that very small space within assisted living. So adjusting our staffing model to determine who's coming to the clinic, when, staggering our schedules, things like that. And then really lastly, minimizing in-facility visitors. So this has been a challenge just because in those assisted living and memory care communities, communication with family is so important. Often their families are their powers of attorney, and we're not able to see them face to face to get those consents to treat signed. We're having to do that electronically, have frequent communication with those family members via phone, for educating them on the diagnosis, the prognosis, plans of care, and progress throughout those plans of care.
That certainly reflects how complicated the process of everything that you're doing is. I think you did a great job of describing that and laying out a picture that shows that it's complicated
Yeah.
and unique in many circumstances. Mark, shifting over to you, can a rehab agency be used to provide services in AL and IL locations easily? And is that better or easier than private practice from the perspective of all of these regulations and how they need to be rolled out?
Yeah, I think great question. Thanks, Laura. I think with the addition of the infection control pieces that CMS has emphasized and now Quad A has formalized in their response, it definitely makes it a little more difficult, right? There are a few more hoops to jump through. And so when I talk with clients about private practice versus rehab agency, we often talk about what's your intent here? What's your goal, right? And how do you manage your business? So from an operations standpoint, when you think about credentialing and some of the burden related to private practice and getting the right therapist in front of the right patient, that therapist credentialed with their insurance and all of those things, if it's, the five of us running a private practice, that's one thing. But if I'm running an organization with 300 therapists who float among different buildings, that's a different animal altogether. Not only from a COVID perspective, but from the RA perspective. So in that regard, I think the rehab agency inside of the IL, AL probably is a better animal to use if we are talking about multiple therapists coming and going, things like that. But again, if it's the five of us, setting up a private practice and I'm the primary OT, nobody else is treating OT but me. And so, it just kind of depends on where your business is, how large it is, and how many folks and moving parts you have within that. The other thing that we often share with our clients when we're talking about IL, AL, rehab agency, is making sure that your IL, AL host understands that you are bringing in another certified entity. That means there is another surveyor that will show up. That oftentimes makes people a little nervous. And so we have to be clear that they're not here to look at anything going on inside your IL, AL, really what's happening in our four walls, and how that interacts with the IL and AL. Then once you kind of explain those things, there's a sense of calm that comes over most administrators. But you need to lay that out ahead of time so that there's not a surveyor that just shows up and it's kind of a surprise and everybody kind of freaks out. Because when that front desk gets the card of, hey, I'm the surveyor, first place they're going to go is to the administrator of the AL or the IL and say, hey, there's a surveyor here. So again, transparency, making sure everybody knows what's going on. One other point I want to make, early in February, so about 2 weeks ago, I think it was the 2nd or the 3rd, we had a client go through survey. So shortly after Quad A put out all of this new information, that was, we had this client go through survey, and knock on wood, they passed with flying colors. They're a larger organization and had already implemented, in most cases, almost all of the things that Quad A formalized in the documents they put out. So in looking at other clients that maybe are a little smaller, they also are doing these things. Maybe they weren't tracking them as well as we would like, or things like that. But for the most part, most of our clients were already doing all of those pieces. So what I would say to everybody on the call is, if you look at the Quad A documents that came out and the CMS documents that came out a while back, they're a bit daunting, but probably you're doing a lot of what's already there. And you just have to formalize that and put it in a trackable process.
And documented, I would add that as well. But I
And
think
that's right.
Yeah, that's a really important place to put your focus. Dick, back to you. How much latitude do the surveyors have in reviewing compliance with these standards, given the unique and different and varied rehab agency settings that we've just kind of highlighted?
That's always a very interesting discussion. The Quad A standards were set up to try to reduce the state operations manual to objective, specific data points, so that we intend that our surveyor won't have to use any subjective notice. If on the form, if it says, does the facility have a policy or protocol to minimize in-facility visitors? The simple way to survey that is, may I see the policy, please, that says this? And when I see the policy, I can say, is it a policy or a protocol? Does it minimize or does it address the minimization of in-facility visitors? Yes or no? Quad A does not ask me, do I like it? That's for the surveyors, or for the consultants. Mark can do that. Nancy can do that. I looked at the attendees and I see about 7 or 8 consultants who I know. And the deal is, the surveyor is just supposed to say, is it there? Like the standard that says there's supposed to be a statement in the discharge summary of discharge diagnosis and prognosis. The question is it there? Not, does it meet your own, always very high standards? It's, is it there, period. And you check off yes. Someone else can decide if they like it. So we try to make it so the surveyor does not have to add a lot of or any subjectivity. As we look at things, there always becomes some, and we try to minimize it. A couple of times I have been on the phone with Nancy and with Mark and with half a dozen other people who are on my list. And they're saying, well, the surveyor came and they said they wanted to see such and such, and they didn't like what they saw. And we end up trying to say, we had one recently on fire alarm. And it was an H-shaped ALF-ILF. And there was a communicating hallway and corridor between them. There was a OPT in the middle of it. The OPT had a fire alarm that was integrated to its own space. And the surveyor said, but it's not integrated to the other parts of this 300 or 400 bed facility. So therefore I'm going to cite it. And we ended up, I called the building inspector for that county. We called the fire inspector. We checked with our own in-house, very knowledgeable director of compliance and regulation. And we came up and said, nope, there was an alarm in the area. It is integrated to that OPT's separately leased space within its landlord ALF-ILF, which, without being judgmental, is essentially a very nice rooming house.
So you really just tried to not get distracted by the extra.
Right. We try to keep them, we just say, answer the question that's set before you. And we have a lot of intelligent people, and they're used to going to graduate seminars where they're supposed to synthesize things. And we try to say, no, just take a look. Is the fire extinguisher there or not? Did you see staff washing hands or not? And we try to back away from it. And then every one of those things gets reviewed by our staff as any deficiency. And when they've all been addressed, they end up coming to the desks of the accreditation committee. And there are 3 of us on the accreditation committee who each review maybe 150 locations a year in the surveys. So we try to make it so it's as objective as possible. Just follow the black and white words of the law.
Great. Thank you so much. I'm going to switch to training for a second. Julia, how do you conduct infection control and emergency preparedness training in your primary and your, assuming you have primary and extension locations in your different communities? And tell me a little bit, as you just answer that, a little bit about how you document that. I think you're muted still.
Sorry. Each of our staff members in our primary and extension sites do complete online training specific to COVID infection control and emergency preparedness at time of new hire orientation. Then each of our staff also completed at least one time in 2020 and at the beginning of 2021 and online in service that we did create specific to our agencies. specific to the COVID-19 infection control and emergency preparedness and our specific policies. So additionally, each agency, the primary and the extension sites, complete regular on-site in-services specific to those most up-to-date COVID and infection control policies specific to their clinic. So additionally, our team is required to complete their daily infection control log, signing off on adherence to those policies and their sanitizing equipment, the gym space, hand washing, use of PPE. And then each quarter, each of our agencies does a quarterly statistical analysis meeting, and the team at that time discusses the most up-to-date COVID and infection control policies and procedures, and essentially do a hot wash quarterly in those meetings, discussing those strengths and areas of improvement.
There's your answer, Nancy, too. Has Julia, has her company activated their plan? They obviously have, and they're hot washing. So that's great. Thank you. Mark, do you think that these updated standards are going to influence positively or negatively the choice to go toward the smaller rehab agencies in the AL/IL space, or what's your thinking?
Well, I think, again, we kind of go back to administrative burden when we're kind of comparing the PTIP versus a rehab agency. And I think in Nancy's picture, one of the things I thought of when she showed the picture of that AL Broome rehab agency, right? We're limiting number of people in the space, but the thing that popped up conversely in my head, as Julia said, we're also scheduling folks in a certain way, was we still have the 2-person on-site requirement if it's a primary or extension location, right? And so you stand in the corner and I'll treat patients over here. We're 6 feet apart. Yeah, I mean, anyway, it gets a little crazy. So I think, today as we look at deciding to go rehab agency, there are a few more hoops to jump through than we had a year or two ago. And so that definitely needs to become part of your equation as you think about, what does my space look like? Do I have enough space to have multiple treating therapists? Can I keep them spaced safely? Can I bring in a couple of patients in that space? And is the space big enough to do that and still meet these guidelines and all of the ramifications of that? The rehab agency has never been an easy thing to do. That there is some administrative burden there. But I think again, it goes back to kind of your business goals. And if this fits in the larger picture of your business and you've already got mechanisms in place at your other locations to already do these types of things that we're seeing from this updated language, then it may not be so hard for you to do that in the new AL that you just added last week. Because you've already have those things in place. But if you're starting out of the gate and it's the 5 of us starting a rehab, well, if the 5 of us did it, yeah, we could do it. But if it were 5 folks who weren't familiar with rehab agency and the guidelines, I don't know that I would start rehab agency. I would definitely probably start the PTIP route and then dip my toe in the rehab agency water as our company grew and see if that was what worked best for us.
I think we're all nodding our heads on that and feeling that you're on the mark with that. Dick, I'm going to come back to you for a second. How does Quad A want our rehab agency how do you want to see our policies and procedures for emergency preparedness or infection control set up? What's if you're walking in, what's the epitome of what you'd like to see?
Well, to begin with, I usually tell people, hey, I'm here as a guest. I work for you indirectly. I'm not here to play gotcha. And none of our surveyors are. When it comes to the policies, we have to be careful to not be prescriptive. So Quad A doesn't want to tell Nancy or Mark or you, here's what you need to have in your policies. All we can do is grab the language of the standard and say, do you have a policy? For example, we have one in the 600 series that says you have to have a policy that addresses basically first aid. under emergencies. It's in the series that talks about plan of care. And it comes out and says you have to have a policy that addresses what you do in case of a medical emergency. What do you do for the patient? Who do you call? What forms do you fill out? I may not tell you what to put in that policy. I need to make sure that there is one. Now, we also tell surveyors, we do peer-reviewed surveyors. We have PTs, OTs, and speech therapists who are reviewing outpatient rehabs. We don't have other people. So I can make a suggestion and say, hey, the standard says, what do you do in emergency? Say that you're going to do first aid, call 911 if necessary, and take care of the patient. The standard says, who are you going to contact? It says, well, you're going to tell the physician, patient's family, probably your agency administrator. If you're in an ALF, ILF, you probably ought to tell that building, your landlord administrator also. And what forms do you fill out? Whatever your agency says is the appropriate incident form. So we're not prescriptive of telling you what the policy has to say. Angie Phillips used to tell us there are some areas you don't even have to have a policy, or you do have to have a policy. You don't say, but we won't tell you what it says, but we will check and say you have to comply with your own policies. So if you've gotten policies from a consultant, may I see your documentation, please, of how you've complied with them? That's the standard biggest question of a survey. May I see it, please?
Thanks. Julia, how about mandatory reporting? How are you guys handling that?
So specific to COVID,
yeah.
We, as I mentioned, our therapists are being tested at least weekly. So, you know, the biggest thing that we're dealing with is those positive COVID tests. Our leadership team does have immediate access to those positive tests, and our area rehab directors are reporting those positive tests to the county health departments, but also the executive directors and the directors of nursing of our host communities, as well as providing those with a list of the residents that were seen within the past 7 days of that testing date. So that those residents at that time can be rapid tested or quarantined until a negative test can be produced. And then as necessary, you know, reporting that to the families or powers of attorney if needed.
Great, thank you. Mark, do you expect the trend to continue with growth of rehab agencies being located in retirement communities? I know you sort of already addressed that. Do you anticipate any differences or changes as you, given your experience in your consulting business?
You know, pre-COVID, the bar none answer would have been absolutely, just based on the way the population is growing. Post-COVID, I think we're probably seeing some of those AL, IL, CCRC campuses rethink communal housing, and how do we still, you know, operate that business model where we have all of these like people in one place that needs like services, but we keep them separate enough so if something like this were to happen again, we don't have these huge outbreaks where it goes from 2 to 5 to 22 to 55 in a week. And so I don't think that changes my answer, though. I think we still, we're going to have to rethink some things. We may think about the space that we're leasing in those ILs and ALs. You know, I've and I'm sure y'all have too, I've worked in those ILs and ALs where we rented the closet to keep our stuff, but we really treat it out here in the hallway. Right? That I don't know that that's going to cut it anymore. We're going to, yeah, don't tell Dick. And so, you know, we're going to be looking at bigger spaces so that we can keep people apart, I think. One thing, and I know we're short on time, one thing I wanted to go back to, Dick talked about the emergency preparedness or the emergency response and the, if you had to call 911. Quick question to Dick, do we have to screen the emergency guys before they come in our clinic and scoop somebody up?
I believe that actually they have a policy because the EMS
Okay.
is a healthcare provider too. And
Right.
somebody's going to be coming in the door. Somebody's going to have to say yes. So there'll be somebody
Wow.
checking
Okay.
a forehead. And
Yeah.
if
Yeah.
there's
Yeah.
an officer on the truck, you ask them, when was the last time you guys were screened? And they said half hour ago.
I have so
Gotcha.
many more questions for you guys. Thank you for taking the time to do this. I might be reaching out to you by email, but we can pull together more content. Nancy, I'm going to toss this back to you to wrap up, and I'm sorry we didn't get through everything I wanted to talk about.
Thank you, Laura, for participating with me and helping put this presentation together, and to Dick and to Mark and to Julia Beckley. I love that. To put this presentation together. It was really, on my part, just really something I'm pretty excited about doing. And I hope that it was helpful to everybody stepping forward. I hope it encouraged you in terms of, getting ready for upcoming surveys and getting your policies together, as well as potentially decision making on whether you want to move forward, as Mark said, in various communities with having a P-TIP or an O-TIP or a rehab agency. So with that, I'll turn it over to Sabrina, our NARA hostess, to wrap it up.
Thank you so much, everyone. This was a great presentation. I know that there are some questions that have come in the Q&A. So Christy will get those printed out and get those over to our presenters to get those answered. Just as a reminder, we did record today's great presentation, and that recording will be sent out to all registered attendees within about 48 hours. It will also contain links to all of the handouts that Christy did put in the chat box for you to be able to access as well. And then for our NARA members, all of that information will also be available on our member portal within about 24 to 48 hours. So thank you, everybody. That was a great presentation, and have a great afternoon.